So patient factors and comorbidities determine outcomes with COVID-19. But what is the underlying pathophysiologic mechanisms leading to the spectrum of illness? There are many hypotheses out there, but one common hypothesis is an interplay between the viral response phase and the host inflammatory response, such that early on in the disease, there's a predominance of viral replication and cytopathic effects of the virus leading to disease manifestation. And this is counteracted by a targeted and localized activation of the inflammatory system or the immune system. But in some patients, immune dysregulation kicks in and there's widespread activation of the inflammatory system leading to a hyperinflammatory state or a cytokine storm state, which seems to mediate most of the features seen in severe disease and likely the adverse outcomes seen with COVID-19. This hypothesis behind disease evolution has been informed by biomarker fingerprints obtained from clinical studies. In those graphs that I show here, non-survivors are shown in red, and you can see that D-dimer levels were much higher in non-survivors as compared to survivors, suggesting possible widespread activation of the coagulation system. And looking at ferritin levels, those were also higher in non-survivors as compared to survivors. And there have been many similarities drawn between the advanced hyperinflammatory state of severe COVID-19 and HLH. Additionally, IL-6 levels are much higher in non-survivors compared to survivors, with an inflection point towards the latter part of those patients' hospitalization course, likely correlating with severe disease, suggesting that elevated levels of IL-6 may be associated with a hyperinflammatory state and severe disease in COVID-19. Furthermore, there seems to be correlation between this hyperinflammatory state and elevation in cardiac troponin I, reflecting underlying cardiac injury, which may suggest that this hyperinflammatory state may have a cardiotoxic effect on cardiomyocytes, leading to cardiac injury. Additionally, in this study, they looked at RNA levels in the blood and compared those in patients who were admitted to the ICU and those who were not admitted to the ICU. And they found out that RNA-emia levels were similar in those two groups, possibly suggesting that severe disease was not likely mediated by uncontrolled viral replication, but rather by uncontrolled activation of the inflammatory system, leading to a hyperinflammatory state, which could mediate adverse outcomes. So what are the cardiovascular complications associated with COVID-19? There have been reports of cardiac arrhythmias, including atrial fibrillation, bradyarrhythmias, and VTVF. One study reported an incidence of around 17% of arrhythmias in hospitalized patients and 44% in ICU patients. There are reports of cardiomyopathy likely related to myocarditis, acute cardiac injury reflected by elevation in troponin, acute coronary syndrome, and shock. And shock is mostly septic shock, though there are cases of cardiogenic shock as well as mixed shock. Here I share with you a case of SARS-CoV-2 fulminant myocarditis reported in the European Heart Journal, where they report a case of a 37-year-old male who presented with chest pain and dyspnea. His CT chest revealed signs of an infectious pneumonia. His SARS-CoV-2 PCR positive and viral PCR for all other pathogens was negative. His ECG on admission showed ST elevations in lead 3 and AVF, and an emergent coronary CTA revealed no obstructive CAD. His troponin T was significantly elevated, and an echocardiogram showed a reduced ejection fraction at 27%. The patient went on to develop cardiogenic shock and was started on norepinephrine and milbernil. Given the constellation of findings, with non-obstructive coronary disease, elevated troponin T, and a reduced myocardial function, he was diagnosed with likely myocarditis and was started on immunosuppressive therapy with methylprednisolone and IVIG for 4 days. He had a salutary response and recovered his cardiac function and was discharged. His repeat echocardiogram showed an EF of 66%. There have also been reports of STEMI-like presentations with COVID. Unfortunately, there has not yet been a systematic series in the literature reporting on STEMI-like presentations in COVID, but given the widespread use of social media for sharing of medical information, I used this report from Twitter from a cardiologist who reports 3 ECGs with ST elevation in COVID-19 positive patients. The first case was a patient who presented with ST elevations in the inferior leads in 2-3 and AVF and went to the cardiac catheterization lab and was found to have an RCA culprit that got treated. The 2 other cases had ST elevation in their precordial leads, but had non-obstructive coronary disease on coronary angiography, and they were finally diagnosed with myocarditis. So you have to take this for what it's worth. We don't have all the details of the cases, but more and more reports being shared among cardiologists are suggesting STEMI-like presentations in patients with COVID-19 who end up not having an obstructed coronary artery, suggesting more likely myopericarditis as the cause. And I just shared with you a case published in the European Heart Journal where a patient had ST elevations and ended up having myopericarditis. So we got to be aware of those patients who present with a STEMI-like presentation but actually have underlying myocarditis. Given those reports of acute coronary syndrome associated with COVID-19 and the challenges this could pose from an infection risk standpoint to catheterization labs, the ACC Interventional Council and SCI came together and put forth some guidelines for cardiac catheterization labs across the country. Interestingly, in China, a lot of patients were receiving TPA as the upfront approach for management of STEMIs. They cited infection control concerns in those patients as a justification behind adopting a primary TPA approach. Just having mentioned presentations of patients with COVID-19 with ST elevation who do not have obstructive coronary disease or a culprit lesion, it seems prudent to avoid TPA as a first approach because we could be exposing patients to risk with TPA with limited benefit. So SCI and the ACC Interventional Council recommended that in patients with STEMI who are COVID-19 positive to adopt a primary PCI approach with meticulous attention to infection control measures, and that TPA remains an option in stable patients, especially if resources are stretched. In NSTEMI patients who are COVID-19 positive, if they are stable, they have recommended medical management first and revascularization after they have recovered from COVID-19, if necessary. In unstable patients, primary PCI is indicated. So what are the other outcomes associated with COVID-19? And I include this to mainly emphasize that this is primarily an infectious and respiratory illness. There are cardiovascular manifestations, but this is primarily an infectious and respiratory illness. So 59% of patients have sepsis, 54% have respiratory failure, and 31% have ARDS. Heart failure occurs in 23%. Septic shock, which is the predominant form of shock, occurs in 20%. And then there's coagulopathy, acute cardiac injury, kidney injury, and secondary infection, which also occur in those patients. With regards to mortality, there have been a lot of reports in varying numbers regarding the case fatality rate. And China is the best place right now to look at the case fatality rate. And not to say that that will not change from one region or country to another, but in China, we know that the epidemic is slowing down, so we have a better handle on the denominator. And because the epidemic has started earlier, we have also more resolution and outcomes for people infected with COVID-19. And based on a recent report, the case fatality rate of SARS-CoV-2 in Chinese individuals infected was around 2.3%. This is higher with comorbidities in patients with higher age. Interestingly, around 50% of patients who were admitted to the ICU died. This is also shown in this Kaplan-Meier curve, highlighting the high mortality of severe COVID-19, especially in patients in the ICU. And when we look at the cause of mortality, we find, again, concordant with this being a primarily respiratory and infectious disease, that 53% of mortality is secondary to a primary respiratory failure. 33% are related to respiratory failure with myocardial damage. 7% are related to primary cardiovascular cause, and 7% remain unknown, at least in this study that was reported. There has been a lot of reports or concern about outcomes varying depending on the burden on the healthcare system, especially in light of what we're seeing in Italy with higher mortality rates there. So some data from China sheds light on this aspect. And in this study, they find that the mortality in the Hubei province, where Wuhan City is located, was much higher than the other provinces. And one possible explanation for this higher mortality is the higher number of cases per capita in the Hubei province as compared to other provinces. Now I'll move on to talk about some of the therapeutics. To start with, there is no proven effective therapy for COVID-19. Treatments are focused on viral inhibition and immunomodulation. Some of the antivirals being studied right now include lopinavir-ritonavir, which I'll mention right now, a randomized controlled trial studying that drug, remdesivir, which is currently being studied in a phase 3 randomized controlled trial, hydroxychloroquine and chloroquine, which, as Dr. Atri just mentioned, has shown some in vitro effect on SARS-CoV-2, and favipiravir, which is being studied in a randomized controlled trial in Japan. Immunomodulators include steroids, IL-6 inhibitors such as tocilizumab and ciltuximab. Tocilizumab is now being studied in a phase 3 clinical trial, statins, and azithromycin. The LOTUS trial was an open-label, randomized control. There has been a lot of promise and hype in the media for hydroxychloroquine, chloroquine, plus or minus azithromycin. Unfortunately, the clinical data is scarce to support hydroxychloroquine and chloroquine. There is promise, especially from what Dr. Atri showed in terms of the in vitro effects of hydroxychloroquine and chloroquine on SARS coronavirus 2. With regards to the clinical data, as it stands right now, there's only the small study from Marseille in France. That was a non-randomized open-label study that looked at 36 patients who were enrolled. 20 received 600 milligrams of hydroxychloroquine versus 16 controls. 6 patients received a 5-day course of azithromycin. There was a lot of differences and discrepancies between the control and intervention arms. In this study, they found that in patients who received a combination of hydroxychloroquine and azithromycin, that there was a higher rate of viral suppression, and by approximately day 5, there was no detectable virus based on nasopharyngeal swab in the combination group as compared to the monotherapy group and control group. Finally, with regards to steroids, there has been some interest in using steroids, especially in advanced COVID-19 patients with ARDS. And there is this retrospective analysis published in The Lancet in patients with ARDS showing that methylprednisolone was associated with improved survival. Again, this is a retrospective analysis and prone to unmeasured confounders as well as bias. We know from prior evidence from the MERS coronavirus and SARS coronavirus as well as influenza that steroids may delay viral clearance, increase mortality, and also lead to secondary infections. So most institutional protocols currently do not recommend the routine use of steroids unless within the context of the clinical trial. And finally, a few words on vaccine initiatives. The NIH just rolled out almost a week ago a phase 1 clinical trial looking at a vaccine. Additionally, Johnson & Johnson have announced a collaboration with the Reagan Institute trying to leverage a vaccine platform for HIV to develop a coronavirus vaccine. A word of caution that there is concern that vaccines and antibodies that they generate can lead to immune potentiation, which could contribute to the hyperinflammatory state seen in COVID-19 and possibly lead to worse outcomes. This needs further investigation, but something to be cautious about in terms of vaccine development and monitoring outcomes. So in conclusion, asymptomatic transmission is most probably what is behind the widespread transmission of SARS coronavirus 2, leading to this global pandemic. COVID-19 has multiple cardiovascular manifestations, including arrhythmias, myocarditis, acute coronary syndrome, and shock. Those usually happen in the setting of severe respiratory illness, but that is not always the case and could happen independently. Mortality and complications are highest in the elderly and adults with cardiovascular comorbidities. Immune dysregulation and hyperinflammations are prominent features of advanced disease stages. Finally, antiviral and immunomodulatory therapies are being tested to impact outcomes in COVID-19, but no proven effective therapies are yet available. I'd like to thank you for your attention, and I'll leave you with this Osler quote.